South Essex Integrated Care Board. Good to see everybody here. Welcome to our members of the public. A respectful reminder to members of the public, this is a board meeting which we hold in public. It is not a public meeting. You are there so that you can witness our decision making and our discussions. Good to have you with us. We were slightly anxious that there might be such demand to be here today that the room would be pushed beyond its health and safety limits. So this meeting is also being live streamed to try and accommodate anybody that might not have been able to be with us today because we couldn't fit people into the room. So if people are aware of that, and it's particularly important therefore that everybody uses the microphones, otherwise that won't get transmitted into the live streaming. So could we quickly go around the table, please? We're here. Welcome today, I think, for the first official time at this meeting, Lucy Whiteman, who is the Chief Executive Officer of Provide for Health, I think. So, Lucy, would you like to say hello, and then we'll go around the table from you.
Yeah, so thank you, and thank you for the very specific welcome. Oh, I have. Bring it a bit closer. So yes, thank you. I'm the new Chief Executive for Provide Community Interest Company for the health side, but also the Group Chief Nurse. But previously the DPH in Essex, so familiar with the patch and work very closely with the DPH for Southend as well.
Thank you. Carry on, Ian, and we'll go around across to Mark.
Thank you. Good afternoon. Ian Wake, Executive Director of Adult Social Care and Health in the Thurrock Capital.
Good afternoon. Mark Harvey, Executive Director for Adult Social Care and Communities for Southend City Council.
Afternoon, I'm Dan Doherty. I'm the ICB Alliance Director for Mid-Essex.
Afternoon, I'm Peter Fairley. I'm a Director in Adult Social Care at Essex County Council.
Hi there, I'm Pam Green. I'm the Alliance Director for Basildon and Brentwood and the Exec Director for Primary Care for the ICB.
Good afternoon, I am Becky Jarvis, the Alliance Director for South East Essex.
Hi, I'm Emily Huff. I'm the Executive Director of Strategy and Corporate Services at the Integrated Care Board.
Afternoon, Matthew Hopkins, Chief Executive of Mid and South Essex Foundation Trust.
Good afternoon, Barry Frostick, Executive Chief Digital and Information Officer.
Hello, Jeffrey Olsen, Associate Non-Executive Member on the ICB.
Good afternoon, Shahina Pardan, Associate Non-Executive Member of the ICB.
Good afternoon, George Wood, Non-Executive Member of the ICB.
Hello, Neha Brown, Non-Executive Member of the ICB.
Hello, I'm Claire Hankey, Director of Communications and Partnerships for the ICB. Afternoon, I'm Tracy Dowling, Interim Chief Executive for the ICB.
Good afternoon, I'm Mike Thorne, the Chair of Mid and South Essex Integrated Care Board.
Good afternoon, Nicola Adams, Associate Director of Corporate Services.
Good afternoon, Joe Fielder, Non-Executive Member of the ICB.
Mark Balaam, Associate Non-Exec for the ICB.
Good afternoon, Anna Davey, Primary Care Member.
Afternoon, all. Jen Kearton, Chief Finance Officer for the ICB.
Good afternoon, Kathy Bonny, Acting Chief People Officer at the ICB.
Good afternoon, everyone. Giles Thorpe, Executive Chief Nursing Officer for the Integrated Care Board.
Afternoon, all. Matt Sweetin, the Executive Medical Director for the Integrated Care Board.
Good afternoon, everybody. It's Neil Maloney, and I'm the Executive Director of System Recovery.
Thank you very much indeed for those introductions. So on we go to our agenda. I'm not going to go through the list of apologies for absence. We'll note those. We've had, I think, no update of the register of interest in particular for this agenda item. I should have said, by the way, that this meeting is always in two parts. It's one meeting, but it's in two parts. And part one is where we have the company of our public members, and then we move pretty quickly, seamlessly to part two, where we discuss matters which are commercial and in confidence. But I've not been made aware of any conflict of interest in any of the items before us today. We then come on to questions from the public. I'm going to summarize the question and then various colleagues are going to respond. Each question has been responded to in writing to whoever raised the issue. So we had a question from Sue Rogers, who queried the time members of the public had to ask questions of the board. Nicola, I think you're going to respond.
Yes, thank you. We provided a written response to Sue, I think maybe here today, just explaining that we need the time to prepare responses, but we acknowledged that this time around, due to the election period, an even shorter amount of time to respond. So we extended the time to respond to questions in this instance. However, inquiries can be sent to the inquiries inbox of the ICB at any time, and we will still respond to those accordingly.
Thank you. Steve Rogers has asked whether the raw data associated with the results of the consultation with regard to medical services in Malden could be shared. And Claire, you're going to respond to that one.
Yes, thank you, Mike. Unfortunately, the raw data cannot be shared, and this is largely due to the fact that the data collection processing note did not stipulate that the information would be shared with anybody in the public domain. So we're unable to share the data. It would have been inappropriate because we didn't have the correct data processing notice to enable us to do that.
Thank you. Eric Watts has asked a question. What progress has been made in implementing NICE guideline NG 197 regarding shared decision making, and what is the intentions in respect of appointing a patient director? That sounds something technical and in your street, Matt.
Thanks, Eric. As I responded to in my last letter, as you know, there's a high focus on shared decision making, both in our stewardship programme, in our Aging Well, and with our clinical lead, particularly for personalised care as well, which have been outlined previously. At present, there is no plan to appoint a patient director, but we will keep this under review.
Thank you. Peter Blackman sought clarification regarding neurological rehabilitation services in light of the contract award for neurological rehabilitation services level 2B inpatients across the ICB, noted in our Chief Executive's report. And you, Tracy, as our Chief Executive, are going to respond to that.
Yes, thank you. And I think you'll see in the report there are two mentions of decision making around neurorehabilitation commissioning. So particularly in response to Peter's question, the contract award was an urgent contract award because the existing contracts for level 2B neurorehabilitation service standards were due to expire. And without a block contract, we would then have to spot purchase for every patient who required neuro rehab, including those that are currently inpatients. If we were to spot purchase, that would be at a higher price than the price we get through the block contract arrangement, but also there is much less guarantee that we would be able to secure places in neuro rehabilitation centres in the east of England. So the executive team took that urgent decision to extend the existing block contracts for a further 12 months. There is work looking at rehabilitation services and neuro rehabilitation services in particular, and the board will be aware that specialist commissioning has now been delegated to the ICBs. That's being led by the Beds, Luton and Milton Keynes ICB. And we expect, and I'm not sure that there is yet a clear timeline, they've only had that responsibility since April, but we expect that there will be a review of neuro rehabilitation and other specialist rehabilitation commissioning. And one of the potential benefits of delegating responsibility to ICBs is it gives us much more flexibility to look at the feasibility, both clinical and financial feasibility of bringing specialised services closer to home, which I think is probably the intention behind Peter's question.
Thank you, Tracy. Now to the approval of minutes of our previous Part 1 meeting of the 9th of May. Does anyone have any questions of accuracy they wish to raise? And you remember that silence is 102% agreement with those minutes. Thank you. And does anybody have any matters arising which are not on the agenda in either Part 1 or Part 2 for today? Thank you. There's an action log. There's 4 outstanding items, but they've still got time to run. So I'm not proposing to to look at those until their, as it were, their time is up. So that brings us to item 6, proposed changes to services at local community hospitals, draft consultation outcome reports. And Emily, I think you're going to lead off on this, and then we're going to welcome, and you'll introduce him, I think, Mr. Paul Parsons, who has been helping us put all this together.
Yes, thank you, Mike. As the board is aware, the ICB ran a public consultation to seek the views on proposals relating to community hospitals, including potential changes to community hospital intermediate care and stroke rehabilitation services, proposals to make Braintree the permanent location of the midwife-led birthing unit in Mid and South Essex, and the potential relocation of services from St Peter's hospitals to other locations in and around the Malden district. The consultation took place between the 25th of January and the 11th of April and has been supported by Stand, Paul, thank you for coming today, and his team, who are expert independent consultation agency. They have analysed the results and are presenting them to us today so that we can consciously consider them. I'll let Paul take you through the content of the report, but I'd like to remind the board of our collective responsibilities and duties around involvement, including on consultations of significant changes such as these, in relation to equality and health inequalities, and having due regard to how we can address inequality, particularly in regard to access, outcomes and services. We also have a specific duty to receive and review these reports. This is our first opportunity to do that, but we will continue to do that within our organisation through to decision making, consciously considering the feedback that we've received from members of the public and staff, alongside other relevant factors that we're considering, like the clinical cases, the financial cases, and practical operational factors. In line with best practice, Stand have allowed for a period of public feedback on the draft report, where they'll take points of accuracy. That runs until the 31st of July, and as part of that, they're holding an online meeting on the 18th of July. I'd like to thank Paul and his team for the huge amount of work they've done to support this process, and hand over to him to give us a summary of the findings from the consultation response draft report. And thanks, Paul.
Paul, if you're using slides, I might just move so that
yes, sorry to put them behind you. Oh gosh, sorry.
and I think also, just in case the slides are not that easy for people to see either at the back or on the live stream, they are available on our website on the virtual viewing platform, aren't they, Claire?
Thank you very much, everybody. Thank you, Emily. Introduction. Should I? Is that okay? I don't want to be too loud for everybody. So, and thank you as well to everybody who took part in the consultation and responded to the consultation. It has been a lot of work and enjoyable work to pull the report together. We wouldn't have it without the input that everybody's given us. So, to recognise that while we're here. Shall I do the next slide thing, please? Thank you. The consultation ran from January the 25th through to April the 11th, and this presentation covers a summary of the output. So the report, the main report itself, you'll have seen, runs to nearly 200 pages. So there's a limit to what we can cover in a few minutes in a presentation. There's also a summary, a video summary on the Virtual Views website, which we've published with the ICB as well. So the consultation covered 3 issues. There were 3 issues in the consultation. The first was options for some potential changes to community hospital inpatient services, and that was around stroke and intermediate care services. There was a second then proposal, an option to move, or a proposal to move permanently the freestanding midwife-led birthing unit for Mid and South Essex to the WJC unit in Braintree. And thirdly, there was a request for feedback on the possibility, in principle issue, of moving all the other patient services at St Peter's to other locations, as the consultation document said, mostly in and around Malden. let's go to the next one. Very genuine with my thanks for everybody's responses. It's been an incredibly strong response to the consultation, and that's not always the case for NHS consultations. So this has given us some really rich data to feed back to the ICB. So 5,500 survey responses is notable in these things. 310 people attended various events that we held. There was a schedule of 10 events that we put in originally. 407 staff members attended staff events through their run through their trusts. 61 people took part in focus groups organised by local organisations. People committed to writing, and stakeholder organisations committed to writing long form responses as well. And 14 groups, individuals and public representatives took the time to prepare evidence and present that at one of the consultation hearing sessions that we held in March and April. So lots of effort gone in from everybody, and again, very grateful for that. The website was popular, more than 20,000 page views with the on the website, and again, notable in these things, there were 216 media stories about the consultation and the issues behind it. And just to note, there were 577 attendees at other events, including 400, an estimated 400 plus, at the event organised by Sir John Whittingdale, the OBA, the MP for Malden, and 1,108 responses to a survey, an additional consultation survey that Sir John ran as well. So members, if we move on, it's okay. So there are two reports that we've provided. First is the main consultation report. That is feedback from all of the channels that we set up to receive feedback from the consultation. And secondly, there is a report of the consultation hearing. That is much more a report of proceedings, and the 14 presenters from that have been, we're asking them to feedback to make sure that we have accurately reflected the evidence that they've given. So to make sure that that's properly presented so that the board can consider that. On the first report, on the draft public consultation report, there is also the report of the additional survey run by Sir John Whittingdale. Now, the keen-eyed of you among you will have noted that that is currently not in the annexes to the consultation, and that is as a courtesy to Sir John. Because of the election restrictions, we're prevented from sharing consultation outputs during those restrictions. So we've only been able to share that with him on Monday. So it just felt right as a courtesy to him to make sure that his office get to see that first and respond. So we will add it as soon as Sir John's office are content with that. So and we'll let you know when that happens. So moving on to who responded. These are the outputs from the survey because they're the easiest to present in a format like this. You can see there were 5,544 responses, unique responses. In there was one exact duplicate, so that one was taken out. But for 5,544 surveys overall. And broken down by district, 71% of those respondents were from Malden district, and then we dropped down to other figures, 9 from Chelmsford, 8 from Braintree, and then on down to Colchester, Basildon and Richford, which were 1%, and Castle Point and Thurrock, which were under 1%. The age range, I think, as well is notable. People between 55 and 74 are most likely to respond. We have had a very strong, again in these things, we've had a very strong response from people over the age of 75. So that's encouraging as well, given the subject matter in the consultation. And again, encouragingly, we've had quite a sizable 108 people under the age of 24 respond. So, which is again a good indicator. Thank you. To start with, some general comments. There were wide calls for the ICB to reconsider refurbishing or rebuilding St Peter's Hospital, and to consider new purpose-built health facilities for the district of Malden. In commenting on moving services, the need for accessibility was high up the list, and making sure that there was adequate space for services to be provided in as well. And general comments included really the importance that the people of Malden see in St Peter's Hospital, the part it plays in their life, and how valued it is. They shared some frustration about how it's arrived in this position, and looking back at that historically. And they told us in detail about a history of broken promises for this is going to be rebuilt, there's going to be a new hospital, and those kind of things which haven't come to fruition. There is hope that St Peter's Hospital can be saved if with the right finance, and a strong feeling, as is set out in the consultation document, that if St Peter's is sold, then the proceeds will be returned to the NHS in the district. So just quickly to go through the feedback, the figures are very clear in the report, and we're going to have time this afternoon. So I'll go straight to the reasons that people have given us, if that's okay. So in regards to, oh, sorry, can you just go back up? Title slide there. Thank you. So we'll start with community hospital, intermediate stroke care, intermediate care and stroke rehabilitation. There were, to this section, there were 2,269 responses to the survey, which gives you an indication of how many people overall were talking about it. There were also hundreds of other contributions made through other of the consultation channels that we set out. And when you read the report, the strength of feeling will be very clear to you. So if we go through to this one, so very clear here, reasons that were given to us, the numbers are here for guidance. Travel and access difficulties were the most often raised things. So there were concerns about increased travel time, the time it would take visitors and other support people from support networks to get there, and the impact that that would have on the patients. There was talk about increased costs of travel, the difficulties that people have with public transport in getting around. There's some interesting work done by Healthwatch Southend, where a volunteer went out to find out actually how long it would take by public transport to reach Brentwood, which was really useful in the consultation. People talked about parking difficulties and the added stress of travel. Lots of the stress was linked with parking difficulties. And the inconvenience and perhaps the time off work and the cost of that as well. And again, the impact that that would have on patients. The closure of St Peter's, loss of provision there came up again. And again, the importance of having St Peter's as a resource in the local community was, and continued inpatient services was seen to be important. Lots of people pointed out that the population is growing and aging, so they need more of these services, not less. And there were concerns about services being overwhelmed, and the care quality and waiting times that go with that. And there were a good number of people who expressed frustration and distrust with the whole process, saying that the decisions were not patient-centric, they were financially driven. So, and again, they mentioned the unmet promises in the past. Can we move on? In terms of the balance of arguments in here, you'll see here the support and the objections to each of the options. It's possibly worth noting right here that there was a difference of opinion between Malden, the people of Brentwood, and the people and staff in Rochford and Southend. So note that as you go through the report. Can we move on? I'm noting time. Can we move on to location of midwife-led birthing unit? So with this one, again, the proposal was to make permanent the move of the centre from Malden to Braintree. There were 2,433 responses to the survey here, again, as a guide. There were hundreds of comments given to us in other forums as well. And again, the strength of feeling here will be clear to you from the report as you read it. The reasons for support that were given in this were that WJC is newer, it's fit for purpose, and there is 24-hour staffing on site. A feeling that St Peter's is not fit for purpose, and there is financial trouble there. Negative experiences are at St Peter's Hospital, and better that it will be a better option for Malden residents. The proximity to Broomfield as well for transfers and handling complications was noted as a positive, and there was some feeling that there was a potential working with WJC to improve outcomes and the confidence of midwives. The reasons for objection, again, travel and transport is the top, and I won't list those things. They are, again, they're clear in the report, and there are lots of similarities with the list before. The losses of provision at St Peter's again, and here the size of the area that the birthing unit serves was raised. The increasing and ageing population leading to greater demand was also in there, and the concern about capacity at WJC and other maternity units to handle that service. And can we move on to the final section? So this was, again, not about proposals, but about the concept of the principle of moving services out of St Peter's. You'll note the difference in numbers here. So 4,447 were more than responded to either the previous two responded here. And there were lots of people who only responded to this section of the survey. And there were hundreds and hundreds and hundreds of comments through other channels. A little bit. I don't know what I'm doing wrong with this microphone, sorry. We are in this a bad idea, neither good or bad, good or very good, and you can see 92% of people thought that in the survey a bad or very bad idea, and that strength of feeling came through in other conversations we had.
The problem with the microphone is if you hold it too close,
it's
got to cut out.
Okay.
So if
Sorry.
you keep it at a reasonable distance, it should stop here.
Thank you. Yeah, so we asked if it was a good idea, a very good idea, neither good nor bad, bad or very bad, and 92% of people thought that it was bad or very bad, and that strength of feeling came through in the other comments that were raised as well. So if we look at some of the reasons people raised, again, the figures here from the consultation questionnaire, the survey, but given to us in all the forums that we had. So again, travel and access difficulties, I won't rehearse those. They're again, a very strong feeling around that pollution, poor public transport, the road infrastructure, all of those issues came to the fore here again. The loss of provision at St Peter's is seen as a critical local resource, and again, the strength of feeling came over there. There were views that included that increased uncertainty would have an impact on the local population, particularly elderly residents. So kind of knowing that St Peter's is where they go, but then where do they go if St Peter's isn't available? The need for more local services, given the new housing estates and all of those large housing developments in the Malden area were regularly raised in the discussions that we had. People thought that it was a valued location, and they valued the services there, and others voiced increased pressure on other services. Again, there's the list of alternative locations for services that were requested in the survey and in the consultation document. And here are a lot of suggestions that came up for where people might build, where the ICB or the NHS locally might build other new services. And one final slide. So it is a whistle-stop tour of what is a big exercise and a large document. I hope that's given you a decent flavour. As Emily said, we have produced the report as a draft so that people can comment on the accuracy. That's entirely in line with good practice. We've adhered to our professional responsibility to report faithfully what people have said. And we'd like to hear back from people if they feel that something particular in there isn't accurately reflected. We published the reports yesterday. This board meeting we're at today, people have until the 31st of July to respond. Again, normally you'd know it was coming, but because of the election, we've not been able to do that, so the period's slightly longer than it normally would be. And next Thursday evening at 6:30, there's an opportunity to join us online for a slightly more expansive webinar than we've got, than we've chanced to have present today. And the decision-making meeting for this will take place at sometime later in the year to be agreed. So thank you very much.
Paul, thank you very much indeed. As you said there, I've had the report for a couple of days, and it's a big report, and I've read it and I'm starting to engage with it. But our task here today, given that you're also going to go, as it were, on the road and give people a chance to say that, you know, you've misreported our views or whatever, that needs to be done. I think what we need around this discussion just now is to ask ourselves, you know, have we done as good a consultation as we can within the constraints available to us? Now, one of the questions that was put to me, so if I can begin that discussion, was, you know, had we adequately made people aware of that we were thinking about these changes, and especially had we made people in Malden aware? Now, from what you said, I heard you say this is a professional body. You think our numbers look quite good. Is that right, or have I got the wrong impression?
Yeah, so this is, there are more responses to this consultation than I think most NHS organisations would expect in the normal run of things of a consultation of this nature. And we've seen that the people of Malden have responded in very great numbers. I think we can judge this on the outputs. There was also there were 216 media stories on the way through as well, so, and TV coverage, which isn't entirely common in these situations. So yeah, there's always learning to be done, but it's a good response.
Okay, thank you. Yes, John Giles.
Thank you, Paul, for the presentation. I guess for me, from an equalities perspective and an inequalities perspective, are you satisfied that we've made sufficient efforts to contact the most vulnerable that are going to be affected by this? Not only in terms of the elderly, but I'm specifically thinking about the underrepresented voices of maternity services around the Malden area.
So we will set some challenges in the equality analysis to start with, and that's been our guiding light throughout. So if I take directly the different groups who are most likely to be impacted, then we wanted to hear from over 75-year-olds. Because particularly for option one, they were going to be, the first consultation issue, they were going to probably be most impacted directly as patients on that. And our monitoring showed partway through that we weren't doing that well enough. So we've stepped up the efforts to do that. And as you've seen from the age profile, there's a good response at the end. So we're pleased with that. Again, the response from women who are likely to have had babies recently or are likely to give birth is that we had to step that up as well, because those initial changes were initial process wasn't responding. We weren't getting the response we need, but again, we got those. So there's a good proportion in that shows in the report. And for the other areas, there's a good showing of people from ethnic minority backgrounds, and there's generally a good showing across the various districts. So there is if you accept the large response from Malden, then there is also a good response then across the other areas.
Thank you. I've got George, then Neha, and then Becky.
Yeah, thanks for the report, Paul. I managed to read it once, so I will have to read it maybe once or twice. Were there specific issues that were consistently mentioned across the different groups?
I think the issues that we've mentioned, we've covered. There is great concern about travel and transport, there's a good range of different things from where people live and their specific challenges. But travel and transport is absolutely a key issue for people.
That was across all.
Across everyone, yeah.
Thank you.
Thank you, Neha.
Yeah, just pressing a bit more, Paul, on Giles's question.
Can you take the microphone? Sorry.
Thank you. Just pressing a bit further into Giles's question, which was around the access, and especially for the second part of consultation, women for the maternity service who've just given birth or are going to. How did we get to that? Because I may have missed it. Did we get we got the demographics? Did we get kind of the gender breakdown as well? And also how specifically, which channels reaching new mothers or mothers about, what did we use for those?
Yeah, so
microphone again. Sorry.
Forgive the newbie. Sorry. So we targeted specific groups that were in the network, and various partner organisations for the ICB helped us reach those groups. And as I say, that initial response wasn't perhaps what we would want or expect. So again, we doubled down on that and reached other groups. You'll notice in the response that we had a couple of participants from the LGBT mummies group, and the demographics for that section of the consultation are set out in the report.
Thank you.
Thank you. I've got Becky, Mark, and then Shahina.
Thank you, and thank you, Paul. Apologies, because it does build on both Giles's and Neha's point. But I'm minded around our duties for equality and health inequalities that it says in the report only 61 participants were engaged through the VCSE forums, and particular, which is relevant for me, the engagement in Southend was quite low. So the report references targeted outreach. So 2 questions: can we be assured that that targeted outreach was enough, and can we do more? And is there a process by which we are going to continue to engage in that way with those groups throughout the end of the consultation?
So I think I can take the first part. I can take the first part of that question. I might hand to Claire or Emily for the second bit. The first bit is, can we be assured that the outreach was sufficient? I think we can always do better, and part of the consultation process is to review the information that's coming in. So set out in that section of the report is the actions that we took on the individual things that we knew. So yeah, I think we can always do better with it. The response in that situation is I think is enough for you to make your decisions, but you would need to assure yourselves of that.
Claire?
Sorry.
Thanks, Becky. And you know, consultation is the formal process around this decision making, but obviously our engagement and involvement work continues throughout. And you know, in terms of how we develop and implement any particular options that we come across, we will continue to work with key stakeholder groups in that, and particularly our voluntary and community sector organisations and our health watch organisations have been vital in that. Yeah, included. So obviously the consultation period for people to feedback on those specific options has ended. This is the report. They can feedback on the report to the 31st. But then after that, obviously, as we're developing recommendations for the eventual decision making, that work will continue to involve stakeholders as we look at what we can and can't do and what the feedback means to us.
Again, just a reminder about the microphones. We've now got Mark, Shahina, and then Jeffrey.
Hi, Paul. Again, thanks for the kind of comprehensive report, and it kind of follows off from what Nihal was just mentioning. We've now got the report, which we've had just for 2 days. Now there's going to be this kind of virtual meeting. There's going to be the feedback on the report. Will we, as a board, get something in addition which summarises that additional feedback, the results of the virtual meeting, and any further changes to the report that may occur because of that additional 2 weeks? So we can then have everything in order to have a discussion what our decision will be going forward.
Yeah, so any items of inaccuracy which are raised and are substantiated, then we'll make those changes. And when it's no longer a draft report, so we'll take the draft off it and share it back with the ICB.
And the finalised report will be again then publicly available so that people can see whatever changes have been made, yeah?
Yeah.
Thank you. Shahina?
Thank you. So just going back to the equality thing. So some vulnerable groups are also have problems with literacy. What steps did we take to ensure that that was mitigated, and what sort of data did that come through from that?
Excellent. Thank you for the question. So, firstly, as standard, we put things out in easy read format as well as we use an accessible form of English in the main reports, and we put it out in easy read as well. We work with the voluntary sector groups around translation. There's a couple of translations in there that we've worked with the groups to pay for, quite often the voluntary sector groups they have the people and they understand the kind of communication needs that their beneficiaries and their members have. So it's a very useful way of us reaching into people that we wouldn't normally reach.
And they supported them.
Microphone, please.
And they supported them in filling the forms out. Okay.
Yes, and anybody could ring the consultation team and get support to fill the surveys in as well.
Thank you. Jeffrey, Matt, and then Joe.
Thank you, Mike. Thank you, Paul. I think for me, the diversity question is really important. And from the board perspective, we'll be looking to see at the breakdown and how that was made accessible and comprehensive. But that's not my question because it's been dealt with. You mentioned about the election and some of the impact it has. I note that the actual consultation was at a particular time and the processing and all of that. Has there been any other adverse effect of the election in any way that you can think of that may have impacted on this process in any way, shape or form?
No, the process proceeded as planned. It was initially proposed to finish 21st of March, is that right? And there were some reasonable requests for extra time and different for different reasons. So it was extended twice. That was still pre the election. The only impact it's had is we were supposed to publish this on the 19th of June, and it came out yesterday. So the election rules prevent NHS bodies from publishing the outputs of consultations during what's known as the pre-election period. So from the moment the then Prime Minister announced the election, we weren't going to be able to do that until after it.
Thank you. Matt.
Paul, thanks for this. Just a question, probably referenced around page 28 or page 29 of the report. On my walkarounds and attendance of events in Morden, I came across some real passionate staff, particularly midwives. I can see you've engaged with over 400 staff from across our system. Are you satisfied that we reached the right staff? And in terms of that number compared to other consultations, is that a good output, do you think, as well?
So the staff engagement was done by the trusts. So we received the outputs of that and have included that in our report. So I can't speak to the makeup of the people who attended, but certainly in terms of numbers, then yeah, that's reasonable. I don't have to mind the number of staff in the trusts that would be affected, but 407 people attending meetings is good in my experience.
Thank you, Joe.
Yeah, thank you, Chair. Paul, in the body of what you presented to us, there was quite a strong consensus of feeling coming back in what you shared and reported, particularly from the Morden area. Were there any notable areas where stakeholders had significantly different opinions? And could you give us an example of that we can get a sense of? Thank you.
Yeah, so I think in terms of the freestanding midwife-led birthing unit, it was pretty much the same across the board. The variances there were quite small. In terms of the different options for stroke and intermediate care, then you'll see that the people of Brentwood preferred option B, which gave Brentwood both intermediate care beds and stroke beds. And that was against the tide of people preferring neither option. And again, there was a small preference for option B, which would give Brentwood that split and put stroke rehabilitation beds into the KIC at Rochford from people local to there and staff at the KIC in Rochford as well. And that was borne out in their presentation to the consultation hearing and in conversations that were had with staff.
Thank you. Now I've got Tracy, and then I think in a moment I'm just going to have to start moving us on just for time management reasons. But Tracy.
Thank you. Paul, you mentioned the extent of the consultation and the survey that Sir John Whittingdale had produced and the report that is currently sitting with him. We did also receive some petitions. I'm not sure if they all came, if their timing absolutely coincided with the timing of the consultation or but either side of that. I just wanted to ask, how have the petitions being considered? Have they been considered as part of the consultation response, or is there something different in terms of us considering the petition content?
So you'll see that we've noted the petition that we were aware of in the analysis report. This board, I believe, has already received that analysis, or so that petition. So that should be considered in addition to the report that we've given you.
Okay, thank you very much. Well, I mean, this is the start of a journey. We've got a lot of reading. We're waiting for the finalised report. All I can do is, Paul, is thank you for the thoroughness with which you and presumably some team behind you are going about this task. Thank you very much indeed for your help.
Thank you.
And I wonder if we could just remind people again when the webinar is for people to hear you go into more detail, just to remind people how they might access that and when that is.
So the invitation is on the website, or people can call the ICB engagement line and book onto the, it's online next Thursday at 6:30. It would be great to see as many of you there as can make it.
Thank you very much. So I need then to move us on. And we come now to the Mid and South Essex Integrated Care Board Annual Assessment 2024-25. Tracy.
Thank you. I just want to inform the board that the Integrated Care Board, in common with the other 41 integrated care boards across the country, has recently undergone its annual assessment with NHS England. We are awaiting the outcome of that assessment, understanding that it's a process that is nationally moderated. So each region will have to undertake the review with each of its ICBs, and then there is a national process to moderate the outcomes. We had a focus on partnership working within our afternoon with NHS England. We had 3 excellent presentations that are detailed when we come to my report later. One from Active Essex, and that really focuses on supporting people's physical and mental health and well-being and making an activity, being active, part of everyday life. We had a fabulous presentation from Dr. Sarah Zaidi and colleagues from her integrated care team, from the virtual wards, from MSEFT geriatricians, demonstrating how they are using data and shared records in order to comprehensively assess people who are exhibiting signs of frailty, and the impact of that work in terms of personalised care for people, reducing admissions to hospital, particularly when people are approaching those last 2 years of life, is really stunning work. And our third presentation was from the Health and Care Academy, and Kathy Bonney's team led that, again with partners from education institutions who we're working with, showing all the work we're doing to attract people to work in health and care, but also to equip and develop advanced skills in our workforce. The second part of the meeting was a closed meeting with NHS England, where we received feedback from NHS England, who surveyed a number of our stakeholders. They were really complimentary about the strengthening of relationships across the system. They recognised the excellence in clinical leadership and innovation that they've seen through the stewardship programmes, and actually that they were seeing in the presentations that day. They could see how much the Integrated Care Board has developed as an organisation, and also suggested that as we are now an organisation that is 2 years old and beginning to mature, that this would be a good time for us to have a look at our governance and have a look 2 years in, as the context of health care and integration is changing, just to check that governance is serving as well and setting us up for the future, and particularly a future. We've got challenges with finance, we've got challenges with performance, but they were really keen to make sure that in addressing those challenges, we don't lose sight of the importance of supporting our workforce, and most importantly, delivering safe, good quality services for our patients. So just reminding us of that those four dimensions of delivery. They were absolutely clear that we must deliver the financial plan for this year, and you'll see through the papers that they've agreed with NHS England a maximum £96 million deficit for this system this year. And so leading on from that, they are concerned to see that there is a strengthening of performance improvement through this system over the course of this year, both in terms of delivery on the financial plan, but also accelerated delivery around wait times, access to services, and some of the outcomes there. So there was lots to build on. There was a real concern that we keep focused on the straightforward things that we know that we have to deliver on, and that we really focus on accelerating the pace of that delivery, particularly around the financial recovery and the performance, whilst not losing sight of quality and bringing our workforce with us and developing them.
Thank you very much. I'm not really going to take questions on that. It's just a report on our kind of scrutiny by NHS England. Moving on then to the annual report and accounts. Again, I don't want to spend a lot of time on these. These go through the committee structures, have been examined in great detail, and they're external bodies who have to say that the financial representations and so on, as far as they know, are okay. Does anybody have any questions or comments, just for time management reasons, given that these have come here? George?
Yeah, I think it should be noted that the auditor was very complimentary about our financial and governance for this year. We had a lot of issues last year, closing from 5 CCGs, and they said that it was substantial. So I think we need to recognise the finance teams and the governance teams for the work that they put into this, please. Thank you.
Here to those teams. Thank you very much indeed. Well done. Thank you. We come on now to an update of our joint forward plan. Emily, we've got the document, the briefest of introductions.
Yeah, no, that's fine, Mike. I'll be brief. As the board will know, all integrated care boards have a requirement to set out a plan for how we're exercising our functions over the next 5 years, called a joint forward plan. In March, we published a refreshed JFP for 24 to 29, which recommits our ICB to the 12 strategic ambitions that we developed with our system partners in 2023. Since then, we have been updating the joint forward plan to take account of feedback we had from NHS England, but also we've been developing the new section 3, which, if approved by the board, will be which sets out the detail on how we plan to deliver on our commitments in 24, 25 and beyond. So this builds on the work that's been done around our operational planning and our strategic ambitions as a ICB, including work with our partners.
Thank you. Questions or comments? I've got one. In a sense, when we put the initial plan together, we had to expose this to our partners, our local authority partners and so on. Is there a requirement that we do that in a particular way, or do we sort of, send it to them, or how does that all work out?
I think the formal guidance is if you're not significantly amending your JFP, you don't have to do the full level of engagement we did the first time round. I'd be more than happy to come and talk to any of the 3 up-tier authority partners or any of our other partners. I have had conversations with both executives at EFT and also EPUT on how we've developed the JFP this year, so they have been engaged. And I would say the majority of these ambitions and delivery plans are partnership working, so it hasn't just been developed by us anyway, but happy to come and talk through with partners should they wish to discuss in more detail.
Okay, thanks. Well, Ian, Mark, Peter, we can be guided by you, but this is continuing steps in an agreed direction, but basically, isn't it? But we can be guided by you if you think people would value a briefing, even for the purposes of re-energizing, the partnership, given that we may have new members that you as officers are engaged with. Mark?
To pick up on your last point, I think that probably is a useful idea given the change in portfolio holders in some authorities. So I think a briefing and update on the new portfolios holders would be useful.
Great, thank you. Ian?
Yeah, I entirely agree with that. I was about to say the same thing.
Thank you. Joe?
Just a technical point, Chair. In section 3, page 4, I think the governance diagram may not be the current one. So just to make colleagues aware, I think we need, before it's submitted formally, to get the right one in place. Thank you.
I think I might have raised the same issue, but we haven't formally approved it until later in the meeting. So been there, done that, but I'm kind of with you.
Thank you, Chair.
Thanks. Mark?
There's a lot of actions and dates within the plan. Is there a process to monitor, track, and then report on whether the actions are completed on time?
So I think that's absolutely in the kind of next phase of work in relation to this, to think about how those are tracked through our existing governance routes. Some of these will fit under the kind of recovery programme, and some through other routes like our core finance committee or quality committee. So that's setting out how we do that and making sure that they fall into our governance will be the next part of this work.
Okay, thank you very much. I'm going to then move us on for management of time reasons. Thank you. We come on to Chief Executive's report.
Thank you, Chairman. I'll take the report as read, and I've already covered the annual accountability meeting. I won't say too much about planning and financial recovery because I think we'll come on to that a little bit later on. In Jen's report, I do want to bring people's attention to paragraph 4.5 around the infrastructure strategy and primary care estate development. The infrastructure strategy is a piece of work that all ICBs are doing, looking at their current estate and understanding of NHS estate and setting strategic direction for how the NHS, in partnership with other public sector, such as local authorities, is utilising estate within its area to best effect. And we really look forward to completing that work. I think that work is that the significant backlog maintenance within the NHS estate, also some significant demands for additional and expanded estate. But interestingly, there is also a lack of really good, clear, up-to-date data and information about how well our existing estate is currently used. So therefore, we need to get that understanding. But you will see from the paper that I am highlighting to the board concerns around the current constraints that really impact upon ICBs in terms of developing primary and community-based estate. So I do want to bring to the board's attention that the NHS premises cost directions for primary care were amended in May 2024, which doesn't happen very often. One of the most significant changes within that is a change to requirements around primary care premises and use of Section 106 monies. And there was previously a requirement that if development of estate was going to be supported through Section 106 monies, that the practice also contributed to investment. That requirement on the practices has been removed, so that utilisation of Section 106 monies. This will enable the use of Section 106 money too frequently not able to be used. This will enable them to be used for relatively small scale development, so practice extension, small scale practice enhancement. So we're just working through where that scope might be most opportune across Mid and South Essex. But the big barrier remains with any larger scale new build primary care infrastructure investments. And we are particularly constrained, and this is a national issue, this is not a local issue, by the business case requirement that needs to demonstrate that the rental reimbursement paid to the developer through the GP contract is in line with district valuers assessments. And with the current costs of construction, that's just not the case. And therefore our ability to progress with a number of business cases for primary care and community-based health centres is stalling because we just can't get those approvals. So I just want to flag that because there are a number of priority developments that we would like to be able to take forward that at the moment are just not getting through that business case process. So I think the board does need to be made aware of that, particularly given the importance of developing community-based health centres and facilities as we seek to move more activity into communities and out of acute hospitals. So we need to be able to develop particularly the primary care and wraparound community estate that. And as I say, that is not a local issue, that's a national issue. My paper also gives some updates on the priorities that the board set for me when I commenced in post, and I won't go through them all in detail, but I do just want to pick out for the board. You'll remember that the staff survey for the ICB had some really poor results. That was undertaken in November. We've embarked upon a significant organisational development programme of and Kathy and her team have done a superb job with that, but actually our entire workforce has engaged with that. We are monitoring that through quarterly pulse surveys, so not just relying on the one annual assessment. And you can see from the appendix in the report that there are lots of areas of improvement. Some areas, though, particularly around people feeling discrimination, where we need to understand more and take further action. Lots of improvement, and we're just doing the second survey at the moment, and I reminded staff on the briefing earlier this week, the more people that respond, the better the intelligence, the more we can make Mid and South Essex ICB a great place to work. And then the final thing I just want to point out is around the performance standards. As I said in my report on the annual review, we made some really good improvements last year, but there is still a lot more to do. I do particularly want to bring to the board standards around urgent and emergency care performance and ambulance delays, and I would like to ask that the board seeks a report or a presentation at the board in September in response to the letter that came out following the Channel 4 documentary. And we've had a letter around pressurised services, and boards are asked to receive assurances around corridor care, around flow for urgent and emergency patients through hospitals and into the community, and assurance around the steps that we're taking to prevent people who don't need to be in hospital from being admitted. And there's some really good work going on across Mid and South Essex, and some really good results from our urgent care hubs, our virtual wards, which are majority step up, so avoiding admissions. But I would like to recommend that the board asks for a presentation from our urgent and emergency care and our flow leads in September to receive that assurance before winter.
Well, looking around the table, we've agreed that, and we will look at that when it comes to us. Thank you. I've got one comment on Tracy's report. Anyone else got any questions or comments from what Tracy said there? If not, Tracy, we're going to say a farewell and thank you informally later on, but it would be remiss not to have it minuted what a difference you personally have made to this ICB. And we will really miss you. And it's been a pleasure to work with you, and you have moved us on. Thank you.
Thank you, Mike. It's been a pleasure working here. I've thoroughly enjoyed it. Thank you.
So we move on now then to the quality report, which is Giles.
Thank you, Mike. I will take the report as read, although colleagues may well recognise that this is a slightly different quality report as has been presented before, as I'm updating the board on a national update of the quality functions required of integrated care systems under the Health and Social Care Act. This is to provide the board with the information of the responsibilities for oversight of specific population groups and functions, including children and young people, those children and young people with special educational needs and disabilities, all age safeguarding, learning disabilities and autism, and also Down syndrome. Currently, there is a gap analysis being undertaken, which will provide clarity of where we are already undertaking these functions, and also where there is further scope and attention required, with a recommendation that the executive team and the quality committee will receive assurance in relation to this, with onward reporting to the board, so that all board and partner members are satisfied that there is sufficient oversight of the quality of the provision of service. The second point within my report is obviously to reference the Rapid Quality Review meeting, which has been held in relation to maternity services at Broomfield, with colleagues being aware of the Section 1 notice being raised at Broomfield Hospital by the Care Quality Commission. My thanks to colleagues from MSC, NHS Foundation Trust, and stakeholder partners for their engagement of the Rapid Quality Review process, which is a mitigated statutory function of integrated care boards, the assurance that was provided of work underway to address the concerns raised by CQC colleagues with their attendance at the meeting, and that further oversight and assurance will be undertaken through the revised and strengthened maternity improvement group within the Trust with appropriate external stakeholders in place. And it was also agreed that should there be any further ongoing concerns which required immediate action, then a further Rapid Quality Review meeting would be convened. I'll pause there, Chair, and take any questions. Thank you.
Yeah, thank you. Matthew, is there anything you wanted to add around maternity? We have to work together on these things.
Yeah, thank you, Chair. I think the Rapid Quality Review meeting was well chaired, and I think the tone was appropriate, given the amount of work and the ongoing response to the Care Quality Commission. We recognise that there is room for improvement, but we also recognise with the Care Quality Commission's current difficulties to wait 4 months to receive a report, and to wait longer than 4 months to receive a report on the 2 other hospital inspections is unacceptable.
Thank you. But we are busy getting on with responding to what has been raised so that we're not guilty as charged, if you know what I mean, on our timely responses. Thank you. Any further questions on the quality report? I think the new format is good, actually. So we come then to finance and performance report. Jen.
Thank you, Chair. So I will take the report as read. You have month 2 in your packs for the board today. I'll just confirm that yesterday we received our planning letter from our regional lead. That planning letter was not in time for being able to be formally circulated to the board, but it should all be in your inboxes informally. That is the conclusion of the planning round for 24-25 finally. In that planning letter, our deficit of 96 million, as Tracy mentioned earlier, has been confirmed. We also have in there excuse me, the list of performance metrics that region and national will be watching us on and looking for assurance on throughout the year. As a result, or in September, when you see this report again, our performance part of this will be expanded to ensure that the board can reflect on the planning letter we've received and receive the appropriate information in that respect. So that does conclude the planning round for this financial year that we are currently in, and we have started a pace on next already. So just in summary, month 2 position, ICB continues to forecast break even, whole system continues to forecast to the 96 million. The construct of the deficit position is 85 million within our acute services and 11 million across our community and mental health services, hosted by EPIT. I would just draw the board's attention to table 2. Because in that you will see that our year-to-date positions for the ICB are starting to show some strain, the same strain that we faced last year, predominantly in our continuing care services, and it would be remiss of me not to flag that now, as that is happening again as early as month 2 in this financial year. We have a very wide-reaching efficiency programme around continuing healthcare and discharge, and we're working with all system partners in that respect, particularly through the flow, the executive flow group we have, which is represented all system partners there. We are not alone in this space. The majority of ICBs across the country are facing significant pressure in their continuing healthcare services. We are still waiting for some final conclusive information around our prescribing spend. We had seen trends starting to level off at that higher level, unfortunately, but level off they have been. But we do know that there are a lot of conversations at the moment about new drugs coming in, which we will need to make accommodation for as we move through the financial year. In terms of the system position, just so the board is aware, there was a reprofiling of our efficiencies delivered. What that has done at month 2 has put the system broadly where it would be expected to be at month 2. However, I would suggest that that is going to demonstrate some challenges, or we will see some challenges as we move through into month 3 and month 4 reporting in this space. We have had stepped up oversight from our regional and national colleagues. We expect that to continue. And we obviously, with our System Recovery Director, are looking at what next to ensure that we are making sure we achieve the pace and focus, which you heard Tracy mention in the opening of the meeting. Broadly in line as we would expect to be at month 2. And in terms of our efficiencies, I would say we have been slow to deliver in the first quarter of the year. However, we are anticipating and have planned for that to increase over the quarterly distribution. I will pause for finance.
Yeah, thank
Take
you.
any questions.
So in terms of dealing with our deficit, within the ICB itself, continuing healthcare, that's gone up. And what is the reason behind that, and how are we going to get on top of it? And then I'd be interested also in how we're getting on within the hospital bit of our overspend, and we haven't unfortunately got anybody here because Paul Scott's on leave from EPUT, but I just think we should rehearse these around this table just now. So in terms of continuing health, I mean, I can imagine that drugs is the prices of drugs as one of the reasons, and there would be others, but can you give us some sort of feel for what's behind this?
So with community healthcare, and Giles may want to come in as well, we are seeing both demand and price, so both volume and price variances in space. We have seen a step change in demand, particularly for those packages for our patients and residents that come out on the discharge to assess pathway, which is where we support speedier discharge from hospital, and we make those assessments out in our community spaces. We are seeing considerable growth in those areas. We do have been under pressure. They are requiring evidencing increased prices in this space as well. We've got a deep dive to actually just go really quite a little bit more down into detail, whether that's specific areas, specific parts of our patch. Is it, are we seeing disproportionate, we're lucky we can benchmark across our 3 hospitals effectively, but are we seeing disproportionate need in different areas across our alliances, etc.? I think, Giles, you'd be comfortable for me to say that we'd be happy to bring that report back, and perhaps there's something about the September you mentioned, Tracy, around a broader focus on performance. I think we'd welcome that in a few different areas.
Giles?
Yeah, if I just follow on from Jen's position, so I think there are further efficiency gains absolutely to be made in terms of process and productivity within the core function of all age continuing care. There is certainly a dedicated piece of work in relation to personal health budgets, which will prove massive dividends, and the forecast is looking positive that we will be on track in terms of seeking for those efficiencies. I think the discharge to assess pathway, ensuring that what we're doing are supporting system partners so that people are able to return home at earliest opportunity or where they call home, is obviously the right thing for us to be doing, which is preventing and minimising any harm by patients being in care or residential home settings where they don't need to be. So there's an awful lot of work that we're undertaking in ensuring that any decisions that we're making are not impacting on risk in other parts of the system. So it is delicately balanced, but pace is now on track.
Thank you. And is it there's new, more expensive drugs are we prescribing? Can you give us a feel for what the issues there are then, Matt?
Thanks, Mike. There are a few, I would say, really exciting medications on the horizon, particularly if we look in the dementia space. There are drugs that for the first time can actually reduce the amount of amyloid or certain plaques in the brain, which is a game changer. These come with a cost, these come with imaging constraints, and it's not as simple as drugs, I'm afraid. It's complicated in terms of the whole process and the way we deliver healthcare at the moment. we can't lose sight of the real benefits of these things though as well. The other thing is in the obesity space, particularly as well, with medicines being looked at potentially to be delivered at the primary care level. There's a lot of national discussion around this because again, really exciting, but if they are not thought through properly, they could have a considerable constraint on our finances going forward. It's difficult because as the medic, I'm excited about these things, but at the same time, we need to be pragmatic and also think about how we best serve our populations, and particularly those that will benefit the most from these new medications coming on board. So new drugs on board, expensive, but we are offsetting some of that with switch to cheaper generics, which have come on in the last year, and that offers at least 5 million plus worth savings in this financial year.
Thank you, Jen.
I would just say the experience we found throughout the last year, and I'm sure that the data when it comes through for month 3 will concur as well, is that whilst volumes have increased slightly, that line is absolutely being pulled up by the net ingredient cost. So the net ingredient costs of the drugs that we are using, prescribing, etc., has increased step change. So this isn't about necessarily just about us prescribing more.
Thank you. Shahina, and then it'd be interesting comments on what's going on within our hospital to address costs, maybe from Matthew and from Neil. Shahina?
Thanks, Matt. Quite excited about the new drugs. Would that then lead us to less people having complications from, diseases like diabetes and things, which will then impact the secondary care and then reduce the cost?
That is the hope, isn't it? I guess the whole focus of our integrated system is to move things towards prevention, and particularly where medicines can support that. But let's not forget the wider primary prevention and lifestyle advice as well, which there's a lot of evidence out there that we just don't do at the moment as well. So absolutely, but there will be an element of double running for a while until those benefits are realised down the line.
Thank you. Niha's just slid under the wire, but you'll be the last one.
Just very quickly, you won't have an immediate answer, Matt, but of course this also raises somehow the negative side of this would be the polypharmacy and the impact of that, which raises both costs and impact on health, at least in the short term, till we figure out what's working, what's not. And it'll be interesting to know our position on that at an appropriate time. Otherwise, Mike will tell me off or ask me a
I think
question
that's just a
requires-
comment, isn't it? But it's obviously something we need to be conscious of. Matthew, an update?
Yeah, thanks, Chair. So just following on the drugs point, we're certainly seeing through the increased activity that we're treating more patients, and particularly in our cancer services, the costs of radiological imaging and chemotherapy are driving some of our increased spend in relation to drug costs. The good news, obviously, is that we are treating more cancer patients and more people through our outpatients and through our operating theatres. But inevitably, we've got to make sure those treatments are as cost effective as we can. I guess the big question for us is, have we done what we said we would do? So we said we would close 80 beds by the 1st of July. We've done that on the Southend site and the Chelmsford site by reducing length of stay, by making sure that patients are only staying in hospital for the most appropriate and shortest time, and making sure they're safely discharged. We'll see the benefits in reduced pay spend coming through in subsequent months. We also said that we would focus on outpatient transformation this year to really make sure the patient experience is much better of using our outpatient services by using some well-used digital tools that are used across the NHS, but also making sure that the communications to patients are much more user-friendly. We've launched a consultation with our staff, as we said we would. That is, as ever, where change impacts on staff, it's creating some concern. The small matter, as colleagues will know, of car parking in any situation, we said our board signed off on our annual plan, which included reinstating car parking charges for staff, and we have launched that process this week as well. So the material point there, Chair, is that the organisation said it would do a range of things to reduce its financial deficit, and those initiatives are underway, but as yet not showing in the reduction of pay or non-pay spend yet, but we anticipate that they will do. Thanks.
Neil, anything you wanted to add?
Well, only to say that when you look at the month 2 position, actually it does demonstrate against the reprofiling that we had identified that we're not far away from the delivery of that as we had anticipated. One of the biggest variations is actually the elective activities. So some of the ambition that we described to go further and faster on our elective activity, and I think partly related to the timeframe in pulling the plan together and getting that signed off. I'm confident that we will get that elective activity back on track and that we will then deliver the ambition that we'd expressed on that financial plan. But that in month 2 certainly represents the biggest variance at that point.
Okay, thank you. Well, on that optimistic note, I'm going to move us on because of time. We come to the primary care. Oh, Jen, no, we need to touch upon performance, don't we, with your new committee responsibilities?
Yes, so I will, as I say, take the paper as read in terms of performance section. Next time the board see this report, it will reflect what's in our planning letter in terms of the commitments that we have made. But what you've got is the core constitutional standards at the moment, and we will develop them. Needless to say, we are not where we would wish to be. We have seen some improvements. We did see some improvements as we exited the last financial year. We are working on how we understand that improvement and sustain that improvement. We have developed now, you'll see later on in the agenda when we get there, the terms of reference for the Finance Committee. We will now sit finance and performance together so that we are making informed decisions in that context. And we will support the reporting of that information in the deep dives through our Finance and Performance Committee, should the board agree with that paper when we get there.
Okay, thank you. Any questions or comments on the performance aspect of Jen's report? Tracy touched on it earlier in seeking a particular report at our next meeting, but there are issues here that we need to continue. Thank you, Ian.
Just on cancer wait standards, the 62-day wait remains. For me, it jumps out as the most worrying thing of this. Is there any comfort on progress around addressing that? Because it doesn't seem to be moving.
Matthew?
It is important because for our patients that are on a 62-day pathway, getting confirmation of diagnosis and getting treatment started quickly is important. We are this as of month 3 seeing that moving back towards the agreed trajectory.
Okay, thank you. I'm going to move us on to Primary Care and Alliance report. And Pam, if we take the report itself as read, but are there particular things you'd like to point our attention to?
Yes, thank you very much, Mr. Chairman. I think the notable points to highlight since last we met is that the publication of the increase of workforce in primary care for this part of Essex are positive. An increase of 19 full-time equivalents in our GP community, as well as a significant increase in the additional roles reimbursement for last year. We continue to attract workforce into this area. However, of course, we are in negotiations with the local LMC on the national agenda around potential strike action from general practice, and that's not something new to the public. It's obviously been discussed in national media, but it's something that we have to prepare ourselves for on a local basis, so that is notable. There's been significant project delivery around dentistry as well, and our care home pilot has now reached all care homes, and this was an area of dental work that was not being done before. So I'm particularly proud of that work and the response of our dental market locally to deliver 90% of activity, which is far in excess of other areas in the east of England. So again, we have a buoyant market here. The alliance work, remembering that the alliances are the delivery arm of the ICB strategies at place and work with partnerships at place and primary care. We have undertaken, in light of the financial position that we find ourselves in, to reprioritise our work. And that means that we're working with finance colleagues to deliver the recovery of that financial position. And that means that we're not doing quite as much of the engagement work that we would normally do at place, but that is priority for the board, that we deliver our position on finance, as well as support our primary care colleagues. We have, since we last met, now initiated 20 out of the 24 integrated neighbourhood teams. So remembering again that is the delivery of partnership at place wrapped around primary care, to give more seamless care to our population. So when we met in the autumn, there was only 9 of those teams initiated, and there is now 20. So Tracy, if you take nothing else with you today, please take that additional 11 integrated neighbourhood teams, which is the delivery model for better care for our population. And Pharmacy First is delivered out to all pharmacies across MSE. So that is support to our population to access care more rapidly in a more local basis, hopefully supporting the system at large to reduce demand. So I will stop there because there's a lot in the report. I could talk about it for much longer, but there are the salient points for now.
Thank you, and don't take them with you. We want to hang on to them. There was a sentence I didn't understand. The ICB has been successful in securing national funding for a hypertension case finding program within dental practices. Is that the dentists, the patients?
It's not the dentist, though. That might be a suitable cohort to work with, given current pressures. No, this is about high-risk patients and identifying blood pressures at point of dental intervention. So it's a novel, novel project. It's good work.
While you're here, I'll put a cuff on you. Yeah. No, that's not cufflinks.
I'm just hoping the blood pressures are done probably slightly before they had their dental work done.
That occurred to me when I read the report. It seemed like the worst possible time to take someone's blood pressure.
Indeed. Tracy, were you looking to come in or no? Okay. Any other comments or questions on this, Shahina and Jeffrey, and then I will move us on.
Pam, thanks. I also note that the report from the region stipulates a metric for dental appointments for the next year. How confident are we will be able to deliver on those?
So as I say, we have a buoyant market in dentistry, much more equipped than other areas of the east of England. We are engaging with our dental colleagues around increasing the activity, and also where we have underperformance against contracts, saying actually, are we starting to rebase those contracts so that we can move that activity around. So it's a piece of work that the team are working on now and in advance of that request.
Jeffrey?
Thank you, Chair. Congratulations on the report and the achievements, I think. So my question is around, I know that nationally there's been some investment in long-term condition service, for example, and that's more around the primary care networks. So to what extent is the Alliance involved in that? And my question is, are we rolling that out? And what are some of the differences we think we could see? I'm thinking more around the wider determinants of health as well, working with the voluntary sector and things like that.
So the wider determinants of health are the key focus actually for delivering care differently at place. We're able to engage housing officers, benefits and revenue officers from local authorities. It is the green environment, all of those things that actually support better outcomes for our citizens. So hand in glove health is actually determined by the lived environment, economic stability. So that the integrated neighbourhood teams, the delivery place for that. So very often we see 30% of the work that comes through general practice is actually non-medical in origin. So is allocated to loss of work, unstable housing, antisocial behaviour in neighbourhoods. So we work with a partnership at neighbourhood team level that addresses those things. So that's actually what we're there for.
Thank you. Anna, you're under the wire.
Sorry, Mike, I know I came in late. I just wanted to reinforce the care home work for the dentistry. It's just such a positive outcome, and I wanted to commend the dental commissioners and those involved in this program, because for as long as I've been a GP, this is an area that has been sadly neglected: oral health in older patients in residential care homes, and this project is working really, really well, and we've had some excellent feedback. So it's been a really good progression. Thank you.
It's really good to hear. Excellent. Congratulations, Pam, and all your teams behind you. Thank you very much. Now we've got some general governance items. I'm going to breeze through these pretty quickly because I'm behind time. There's a board assurance framework. Trace, is anything you wanted to highlight very quickly?
There are two things quickly. So first is an increased risk of workforce, and that is particularly if you read the detail of that report. There has been success in addressing vacancy rates, reducing turnover, reducing sickness, but our use of bank and agency staff has not reduced sufficiently, and it's the major risk in our financial recovery plan. So that workforce risk is increased. The level of risk around primary care is reduced for all of the reasons that Pam has just talked us through. And also we've slightly reduced the risk around urgent and emergency care and system coordination, because we are performing relatively well. Now we can do better and we will do better, but I think this now more accurately reflects the level of risk that currently exists. There's some really good system work there, and much to build on, as I hope we'll see in September when that comes back.
Great, thank you. We've got some revised committee terms of reference. These have the approval of the committees themselves. Are you happy to approve those? Giles, no?
That's fine, don't worry.
No? Yes. Did she just look at you and then you agreed? Could affect you in your budget, you know, don't you? Okay, very good. And we've got some new policies. Again, they've been through scrutiny elsewhere. Are you happy to note those? We've some committee minutes to note, and I assume that the chairs of committees would raise issues if there were things they wanted to draw to our attention. And we've got our ICB corporate objectives. Any questions or comments on those? I'm wanting to move us on. Okay. Thank you very much indeed. So that concludes part one of our meeting. Thank you very much, members of the public who joined us. We now ask you to leave as quickly and quietly as you can, because we need to go on with part two, and I'm running behind at the moment. Thank you for your attendance with us today.